the Medical Commission. About 4 months ago, we reached out in the aftermath of the commission investigation to the Department of Corrections because we had a number of questions, and the engagement from DOC wonderful. Very patiently answered the immediate questions that came out of the Panel B case. But they also wanted to engage further with us. I know that in many cases, DOC cases for the commission generally have an extra layer of hard to understand because we don't understand the DOC medical care system. And so today, we have two people who have graciously volunteered to come and talk to us. They are also more than happy to answer questions, whether it's logistic, bigger picture questions. And so I'm going to ask Dr. MaryAnn Curl and David Flynn to come up to the podium and introduce themselves. And then they have a presentation that, again, hopefully will be followed by questions both in the room and from online. So thank you for being here.
We are so excited to be here. I'm the Chief Medical Officer for the Washington Department of Corrections, and we have been together as a team, David and I, for 3 years, and are planning really to keep at it. We have been on a mission to transform the care, primary care, mental health care, addiction care, dental care, social work, clinical pharmacy services. We're going to tell you more of this story, but we are on a mission, and it is really heartfelt, and we're just excited to be able to tell you our story. We are open books, so any questions that you have, we are glad to answer them. If we don't have the answer, we'll tell you we don't, but we're glad to follow up with you. We hope this is the beginning of a conversation, and that we can continue to partner together for a healthier Washington.
And as MaryAnn just stated, I'm David Flynn. I'm the Assistant Secretary of Health Services. Been in this role for 3 years. And when Dr. Curl speaks to the team that we're building, the foundation that we're building, there's a partnership that we've established that goes beyond just team and building the foundation. We're modeling for the rest of our division and the rest of our agency for partnership. What collaborative decision making looks like, what just culture looks like, and the commitment to improving outcomes for our patients, and all the labor that it takes to get that right in place. And I want to say how grateful I am for the partnership with Dr. Curl and for the opportunity to share the work that we've been doing with you guys.
Hold on.
Some distracting. You never know. We'll get it back up.
Yep, and down. Down, up. Yeah. It's all good. I can go down and go up. So I'll call her. So, Dr. Murphy and I were just talking about this, but I wonder, and you don't have to volunteer your information, but maybe just if you have a notepad or just think for a minute, what do you know about corrections? And how do you know that? Anybody want to offer up their at a certain time?
I am a medical malpractice attorney, and I also do criminal defense in a small rural county in Washington. And one of my questions is going to be where these efforts in DOC interface with the local jails. Because I'll tell you about my experiences in the local jail is that the mere existence of healthcare of saying they have healthcare is sometimes just a mean-spirited, cruel joke. I've had clients, I'm speaking directly from experience. One gentleman a couple of years ago had kidney stones, passed several kidney stones in a few months before he was going out, or in the year before he went to jail. He started complaining, oh, I think I have another kidney stone. They dismissed him. And when I went in to see him for the third or fourth time, he told me that he had not been able to urinate for 4 days. He was clammy skin, yellowish skin, yellow sclera. And I said, when's the last time you talked to medical? And said, just today. So I went and threatened the chief with, or the captain there with a lawsuit. If they don't get this man to an emergency room, he has the kidney infection. And of course, he was admitted for more than 30 days into the hospital with a kidney infection. I've had a lady who went in with an abscess tooth. And they told her, like they tell a lot of them, oh, you don't have a medical, that's not an emergency, handle that when you get outside. Over the next several days, she started getting inflammation and red streaks going up her jaw. They started complaining about blurry vision in her left eye. And again, I go to the captain and they're telling her the whole time, that's dentistry. We have a volunteer dentist, a mobile dentist who comes to the jail every other month, and he'll see them. And so I went, this is the trigeminal nerve. This is a medical issue. This is not, something simple. She had to have surgery. I can go on and on and on, up to and including the lady who died because she had been beaten so severely, and she was complaining until she got in trouble for pushing the emergency button, until she stopped pushing the emergency button and they found her dead the next morning.
Yeah, it's horrible. Sorry to hear that. So jails, we have 59, I think, 39 counties, excuse me, I'm from Texas, so we have 54. 39 counties, and each county jail is kind of its own entity, and the funding is its own entity. It's not hooked in to the Department of Corrections. Generally, people who are less than a year in the system are in the jail system.
what it looks
Once
like.
they're going to be a year, they go over to the prison system, and that's what we're in charge of, is the prison system. Subsequent to our system is we have reentry centers around the state where people are still in confinement, but they're living in the reentry center and then working in the community and kind of ramping themselves into their post-prison life. And then we have supervision in the state. And so we'll have people who are, it's probation parole in other states. In Washington, it's called supervision. And you don't have medical care past the prison mark right now. We are working with Medicaid, and the kind of our last slide is about the Medicaid transformation project, to have a 90-day pre transition and a 90-day post window to partner with the community that is Medicaid funded, and that is much more avidly connected. The jails, your concern is our concern. One of the things we're going to speak to later is the electronic health record and the enterprise-wide connection. I think one of the enablers of changing the reality of the absence of access is transparency. And if you have the ability of someone, the Department of Health, whomever, is able to really take a look at the quality of care in a transparent way and defragment the system, put the puzzle pieces together more, then I think we have a prayer of actually developing and attaining a standard of care that is consistent with humanity. And I would agree with you that we do not have it now. And I would just say that is why 4 years ago I joined the Department of Corrections, because I was convinced that somebody needed to do something about it.
From the same team.
Absolutely, 100%. And I have two brothers that are attorneys, so gotta say that.
I just wanted to add on the commitment that Dr. Curl just shared that we have to improve quality of care. Back in 2020, 2021, prior to us coming into our roles, the Office of the Correctional Ombudsman identified primary care in the Department of Corrections as their #1 concern. It's part of the reason that Dr. Curl is in her role and that I'm in my role. I would like to elaborate a little further on the impacts of not having an electronic medical record. Yes, we do have connection with the county jails. Yes, we do receive our patients from the county jails. Do we have all the information that we should when we're receiving our patients? No, there's no full unknowns that we don't have access to. Absent an electronic medical record, we will not have full information about the patients that we receive. We have worked with WASPIC to improve communication, to have some information on the patients that we're receiving in some situations from some county jails, not all county jails. But it's paper-based, just like the rest of our health records are. And does it lead for opportunities, things to be missed? Absolutely. Any paper basis.
So does anybody else have anything that you want to offer in terms of experience with correctional care? Sir?
Well, I just give the flip side that I work over in Spokane. There, Bulgaria. Low, I think that's not life threatening for people's about ice cream prison. And the patients there would be treated as essentially any other patient. You know, I walked in and I was responsible for going into those doors. Going to prison is nothing like walking into a prison and having that first time the jail door slams behind you and you're not sure you're coming out. And to go in the room and you're in a big room and basically you're left alone, the guards are outside. There are young men who got defibrillators if they needed them because basically you treated them just as a patient and not as a prisoner / patient. Never looked at the chart to find out, just wanted to know. One of the first people that I put a defibrillator in Spokane 20 plus years ago, that would be 30 plus years ago, the guy who actually in Walla Walla high security prison had a cardiac arrest, and they told me, somebody did tell me he was in for murder. And eventually he got the defibrillator. They discharged him from the prison. They said, you know what, it's going to be too hard to take care of you. So you just go out, and whatever number of years he had served, and saw him over the next 15, 20 years of life outside of prison. So there's one spectrum where they're ignored, and then there's the opportunity to take care of them very much like anybody else.
It's the jails and the prisons are, in my mind, if you think of put a medical model on it, it's a little bit like being in an emergency department where you have people who are churning through at a really rapid pace, and it's really hard to get traction on that. That's the jail. And then we believe ourselves to be a stable platform. We have, on average, about 30 months with our patients. I can walk out to the unit where this person is residing and continue to talk with them about preventive care. I can continue to counsel them on their diabetes that they're trying to manage. We have dental care, we have mental health care, and my job as the CMO, the Chief Medical Officer, is to work with my partner to resource that care and to help not waste resources and to help people be in the right place with the data they need to make the right decision, trying to drive toward 100% of the time, right? And I do like the fact that when our patients need a defibrillator, I can get a defibrillator for them. We can get them cancer care. We can get them the appropriate care for curative hepatitis C treatment. We have right now, the HIV patients that we have in our system, undetectable viral loads 100%. That's pretty impressive. and I compare to the community, and I feel pretty good about what we're doing with that. Where we're drowning are the same places where society is drowning with addiction care, trying to get enough resources to stem the tide of opioid addiction and stimulant addiction. Those are places where it feels like that we all just need to grab arms and try to figure out solutions throughout the whole continuum. We're gonna get to that. I'm gonna go ahead and stop the beginning of this and let Dave get to the actually substance of our presentation. And please, if you have questions, feel free to ask them. If it's in the moment, that's absolutely fine. We can handle it.
I do, and I do want to make one quick comment. I appreciate everything that you shared about your experience. And correctional healthcare, it is public healthcare. 97% of the people incarcerated are coming back to our communities. Providing quality care to people, it improves the health circumstances inside our communities.
Just tell me when you're ready for the next.
This is yours.
What is it? Okay, we didn't like tag these slides, but so the idea that we have, the concept that we have is that we really want to be the ladder on the left of making attainable steps for our staff and for the population that we serve, so that people can be successful. The population that we inherit from the jails and from society are people who haven't had access to care. I've been in Department of Corrections since 2020. I actually started right when COVID was hitting like a dummy, but anyway, it was interesting. April of 2020, I started, and in the 5 years that I've been working in the Department of Corrections, the natural course of disease has come up in my mind more times than I can tell you. Like, wow, where has this person been? My goodness. And our response is meet them where they are, help them to understand where they are, and improve the situation. We believe that we can be instrumental in the human beings that we care for in our prison system to be better health consumers, to be better members of society, to be better neighbors for all of us. And we believe this platform, if we play our game right, if we do it right, can really, really substantively make Washington healthier. So that's what we're dealing with. I'm trying to get this thing to Lord. I don't know if I'll do it that way. Yeah.
So there's two things here. One is our organizational structure, which can be deceiving. Because as the Assistant Secretary of Health Services, really, you can look at my role as being the CEO. Dr. Curl is the Chief Medical Officer. Her picture is lower than mine on this org chart, but it's not real. That's not the reality. We're peers. I do supervise Dr. Curl. Dr. Curl coaches me, teaches me, and we learn together every single day. The rest of our team are relatively new in their roles. This is a new team. We've been together, completely together, less than 3 years. 2 deputy assistant secretaries, 1 oversees all of our operations. So essentially, chief operating officer. And then the second is our deputy over quality and regulatory compliance. Because ensuring quality is incredibly important to us. And both of these roles are new within the last few years. We didn't exist prior to Dr. Pro and I coming into the organization. We have 11 prisons across the state. There's 2 prisons divisions in the Washington State Department of Corrections. Men's Prisons Division, which consists of 9 correctional facilities, and then the Women's Prison Division that has 2 correctional facilities. And we provide different levels of care at each of the prisons across the state.
Go ahead. I was just gonna say, I just put the scattergram in just for completeness sake. You guys have this PowerPoint, I think. And so it's just for interest's sake of what we provide where. That was my fault, Dave. Well, it's no fault.
So in this last 3 years, we have established a governing body to oversee all of our healthcare in the agency. It consists of a political service board, an administrative service board, quality council, all that report up to our governing body. Our governing body are the 5 people that were on the previous slide. Dr. Curl, myself, the other 2 deputies, and our chief nursing officer. You look at this graph, and these pillars could look like they're silos, but they're not. They're actually cylinders of excellence, because our clinical services board, it's not just clinicians. Our administrative service board, it's not just administrators. We work in collaboration with one another in everything that we do. We look for the right people to solve the problems that we have so that they can utilize the curiosity, push what our norms are, and look for new ways of doing things. So as an agency, our mission is to improve public safety by positively changing lives. Our vision is working together for safe communities. And our commitment is to operate safe and humane correctional systems and partner with others to transform lives for a better Washington. Our agency values are cultivate an environment of integrity and trust, respect and inclusive interactions, people's safety, supporting people's success, positive words and actions. Our agency strategic plan has identified 4 strategic goals and priorities: safe and humane systems, successful transitions, healthy and engaged workforce, and an equity, diversity, and inclusion and respect culture. Go to the next slide, please.
Yeah, this is where we put it into action.
This is absolutely where we're putting it into action. So in health services, we've established 7 strategic objectives to advance the agency strategic plan. And as we establish our 7 objectives, we look for things that would be foundational. But the most important thing to us was that our staff would be able to look at any of these objectives and intuitively be able to see themselves in the work that we're doing. We put a focus on hiring DOC state employed nurses over contract nurses because we know the rate of harm goes down when we have people that are stable, where we don't have a transition constantly happening, where we don't have the burden of onboarding on a regular basis, and people actually know our system. Not only does harm go down, satisfaction goes up. All of our staff find the value in that. Improving patient access to care. We have put focus on improving patient encounters for primary care, nursing encounters. We recently included mental health and dental. All of our staff see themselves in that work, and our patients see the value in the changes that we're making. And we'll talk more about those changes a little later in this presentation.
So I'm going to tell you a little story of an improvement that we embarked on at Shelton, which is the men's reception center. So when you look at the interface between those county jails, this is where the men who are going to be incarcerated for more than a year will come in through Shelton, and then they'll get their intake physicals in primary care, in dental care. They'll get an assessment in mental health care, and if they need additional mental health care, they'll start establishing those needs. This is where we hope and continue to work to get that continuity from the community if they were being seen, if the jails do know, about medications they were on or conditions that they were managing. And we try to continue to work on that interface being more avid. When COVID was happening, and I didn't tell you my story, but I joined as a locum tenens physician And then I was quickly asked to help go and run COVID outbreaks. And so I was fortunate to go all over the state to help run the COVID outbreaks that we had and to reduce risk. We did an incredible job. I don't know if you all know, but we had Washington State Department of Corrections had one of the lowest rates of untoward events and deaths with COVID that you can find anywhere in corrections. We did a great job, so very proud of that. What happened though with that is that we learned a lot of things about cooperating as healthcare workers with our custody partners. One of the things that broke all of our hearts during that time is we had exhausted the times that we could have the governor request to hold the buses from the county jails to come into Shelton. And so we couldn't move people out because we had outbreaks, but we only had so much space. We had people sleeping 3 in tiny rooms and tiny cells. And I'm going to give you a word, and I hate this word, but I'm going to tell you because this is one of those traumatizing things. The third person in a room they called the rug. So that dehumanizing factor of making you just want to just have you a visceral reaction to that, right? I have a visceral reaction to that every day. We had 100 to 150 people having to sleep on a mat on the floor. So when we got more stable, we said, we're fixing this. We had 850 people awaiting their physical. And we said, we're going to get that now. So this is the story of how we did it. And kudos to the Shelton team. And this is just me telling you something we've already, I didn't know if we would have told you, but I wanted you to understand the context, reception, and continuity of care, and the transition of post-prison. I think I've gotten this. What we did is we have consultants with Moss Adams Group, which is a group that worked with Virginia Mason to improve their whole system of care back a decade, 15 years ago. And we have contracted with them, and they came in and they taught us how to think. And they taught us how to really work something and make it stick. And so we did analysis and we did lean transformation of our processes at Shelton to make sure that we could get our intake physicals in an appropriate time. We conducted literally stopwatch time studies with ourselves of how does this work? And we did this is the 3 kind of trials of we had this tent, which is about maybe half as big as this room, that we can kind of play with the setup of the tent and do timing on ourselves and see how the flow of the visits went. And so that enabled us not to be tied to one particular model, but to continue to keep trying to improve it. And so you can see we went from tangled up spaghetti where someone would be running, 5 miles in the tent to 2.5 miles in the tent to, oh, here's a nice loop of U-shaped, flow. And we went from an hour long for the physical to 14 minutes for the physical. Right? And guess what? Here's our backlog. Orange is the physicals needed. And gold is the backlog of physicals that by the due date. We crushed it. We had a 99% reduction in the initial physical backlog. You say, yeah, but everybody can fix it while they're watching it. This is what it looks like now. We're still maintaining that plateau of supply meeting demand. And that's through losing staff, having to rehire staff, doing the things, and people having, things like other distracting factors. We're able to actually sustain it. And this is a really big deal. Dave's going to tell you a little bit more about, why is this a really big deal ahead of just when to be really appropriate with patients getting the physicals they need. There's a custody reason for it.
So I'll share. Most of my career, my background is in prison operations. I've been a superintendent at multiple facilities, started as a correctional officer, and have been working in healthcare for the past 5 years. Most of my career in Washington State, there have been people sleeping on floors. That leads to violence, that leads to people being treated incredibly poorly. It leads to backlog in the system, leads to violence. It leads to people creating debt for themselves when they're staying out of reception centers too long. It prevents them from moving on from the reality of what their sentence brings and how it impacts their life. It doesn't allow them to get to a new normal. Getting people to a parent facility is incredibly important. The parent facilities are better suited to meet the needs of patients, not just in a healthcare, from a healthcare perspective, but from a programming perspective. From getting stability, a lot of people come with nothing, and they lose all the support that they have in the community. So getting people processed quickly and appropriately and getting to a new reality of what their life's going to be during their sentence, where they can start to normalize their new reality is incredible.
So what we saw with our custody partners and the feedback that they gave was the reports of violence went down fivefold. We were having 10 a week, we went down to 2. The severity of the violence was also diminished. The demand on the correction officers who are constantly trying to process, all of the community humanity into the system and get to that more normalized state, the new normal where people can feel stable enough to really start addressing their therapy needs, their medical needs, their physical needs, had the dividend of reducing the demand on the corrections staff by reducing the demand for, showers. Like you actually could move people to a different prison facility so that the receiving facility wasn't so overcrowded. Reducing the mealtime demands, lowering the unit operating cost. The cost was incredible. I think it was like $1.6 million a month of the difference in efficiently doing the work and letting the work stack up and do a batch. The overall overtime expenditures went way down. And then the morale of the staff to say, first of all, we did something that's meaningful to us and we can sustain it, but also someone cared enough to come in and help us to figure it out. It was very empowering. So this is actually the slide that the whole last several slides is looking at. How does what we're doing in corrections differ? How does the healthcare differ from the community? And so I put some side-by-side comparisons. The patients in the community, I don't think it's really honest and fair to say they just have free choice, but they have a lot more choice than what our patients have. And so Dave and I feel a huge responsibility to make sure that our staff are worthy of that responsibility, that we're really taking a look at mentoring these people and really having a high standard of care that our PAs and physicians bring to the table. And we're constantly working on them. I have 28 physicians. I know them all by name. I have one-on-one conversations with every single one of them and every single PA. We have a spectrum, as you would imagine in the community, that everyone has a spectrum of different skills and talents and different avoidances. We have a culture huddle that I lead every single Thursday where we're talking about growth mindset, the possibilities of where we're going with developing ourselves to be better caregivers. And every single month, we have staff psychologists come and teach us something about reducing burnout and improving our self-care. And I think that's very directionally aligned with what we see in the legislature this year in terms of support for providers in Washington State. Scheduling. The patients can't know when they're going out to the community. That's a weird one. Like to try and coordinate with your patient and you can't tell them when their appointment is. So we have a bachelor's degree program where people are in school. We have vocational programs where people have jobs. We have all kinds of programming that people do to improve whatever it is that they need to work on while they're in. So coordinating that with medical schedule it's pretty tough when you can't engage with your patient around, hey, when do you want to do this thing? We've been working, Dave and I, for the last 3 years to, if they're on campus getting that scheduled appointment, does anybody have a security reason why we can't openly talk about that? And we're working toward that. I don't think we have it completely, but we're closer than we've ever been to getting that partnership of yeah, that's kind of the reason to talk about looking at opening scheduling so that each of our patients actually has their own Securus tablet. It's like an iPad kind of a thing. And we're looking at, can we use that electronic platform to help them feel a little bit more agency in the decisions that are made around how they're spending their time and reduce no-shows in clinic, all those good things. Getting to clinic, when was the last time you had a patient that had to be escorted in your clinic? Or have to have 2 officers to open the door for you to get to your hospitalized patient? It's weird, I'll tell you. But it is what it is. It takes more time to do those visits. You have to be situationally aware. I will say personally, I've never once felt unsafe in prison. In fact, probably when I look back on my time, the community work that I did prior to being in the Department of Corrections, there were just so many unknowns. Somebody could walk in and there's not security there. The focus on the care, we have a big responsibility for population health. Just think about hepatitis C, HIV, TB. Probably you read that we had the largest TB outbreak in the history of Washington State. It was fun. No, it was not fun. I'll say that really quickly so that nobody misconstrues me. It was horrible. The patients were scared. We had a lot of work that we had to do without additional resources. And we took it really seriously. It was long days. We have things that come up all the time where we had one day where I got a call from my infectious disease doctor and said he thought maybe we had a hepatitis A case. And, there's a lot that happens when people are living in close quarters and you have something that can be transmitted pretty easily. Just like college, the military, prison, right? Just in development places. Of course, we talk about decision making. We have to actually think in terms of what we call it is kind of the medicalization of life. If someone needs a mattress, that might become a medical decision. And it doesn't make sense, like shoes, is that a medical decision always? I mean, we have that happen a lot. Durable medical equipment is normal, but we have a lot of things in our environment where I'm asked as the chief medical officer to kind of adjudicate whether or not somebody gets something. And I'm thinking, I don't know if they should get this, and so we have worked over the last 3 years to really, really team up and try to set a reasonable, appropriate standard of care that is statewide, that it's not this facility does one thing one way and this facility does it different. The jails are kind of in the mix, like, can we figure out how to do that? But the 11 facilities that we have, we try to have a reproducible standard of expectations so that someone, the average person who stays for a while, so I think 7 moves is the average for someone. So they might see 7 different facilities. And we want to make sure that we have a reproducible kind of experience for them, and positive experience. So I'm gonna skip this one, but because I'm gonna let Dave just kind of tell us what he thinks about the people that work for us.
So when we started this presentation, we asked you, what did you think that you knew about correctional health? In other rooms, if we ask that same question, some of the responses that we'll get is that the quality of care is less than, that the people that work in correctional health care are there because they have to. They don't have anywhere else to go. That we provide only constitutionally required levels of health care. Our patients are the only people in the country that have constitutional guarantee to health care. Everyone's assumptions on people not having other places to go and quality of care is less than or 100% wrong. We've established credentialing in our system. I can tell you right now, we have no one that had enforceable actions against their licenses. Our providers are board certified. They're intelligent, they're curious, they're tenacious, and they're committed to improving the care of our patients. I believe a lot of that is from the model of Dr. Curl, that she gives people the room to be able to be curious and push our system. In fact, Dr. Curl pushes on me every single day. And I've got limitations on the things that I'm able to do. But that healthy tension that should exist between Dr. Curl and I, it is healthy. And it's alive, it's well, and our staff, they benefit from it, and they utilize it.
So that was one thing that when Dave and I were kind of talking and setting up our partnership that I insisted on was that each position would be board eligible, and if they were board eligible, they would be certified within 2 years of hire. And that is on every single required, on every single position. We looked back at the history of what had happened with healthcare in the Department of Corrections in Washington State, 10, 15 years prior. And I was very compelled that had to be a minimum standard. I require, yes.
What are most of them wanted in?
Yeah, I was going to say, I require family practice or internal medicine. We also have a cardiologist, one. We have one orthopedist. We have a nephrologist. We have a neurologist. We have infectious disease and prevention of 2, plus a nurse practitioner there. Let me think. We have several who are hospice and palliative care boarded. So I'm double board certified internal medicine and geriatrics. And then I did 16 years of hospice work. And so I didn't go back and do my board certification that you should have, but I was the chief of staff of the VA at the time in 2012. And that was the last year he became grandfathered in. That said, I think I've got too much on my plate. So did not do that. But let me think if we have any other specialists. We're always open, so if anybody wants to volunteer, and I'll give you a part-time no, this isn't supposed to be commercial. So we're going to shift to kind of get a little bit of show and tell for a minute of the things that we're doing, and some of the things we have a lot of projects going on. I will say, what we do is we get together and we talk about the mental picture of what we're going to do, and then we just start building it. We built the governing structure. We had 0. We got there. We literally did not have a governing body. We had a mental construct of what a quality program might look like in the possible future, and we took brick by brick by brick and made a physical presence of that. In fact, our conference room in our offices is what's called an OBEA, and it is basically a visual management room of the things that we are prioritizing out of the hundreds of measures that we have. So one of the things that was one of those middle creations that Dave and I then said we're going to make into reality. And one of the reasons I said yes to being the CMO was a patient-centered medical home. And I don't know if you all have ever had any interaction with a patient-centered medical home, but what we had in Washington Corrections before was a provider-centric model where the provider was supposed to just take care of all the steps and everyone. We didn't even have any medical assistants that worked in the Department of Corrections. We didn't have nurses who worked with doctors. They were in these parallel worlds of doing kind of what they thought was best. So there was no teaming. There was no actual like thoughtful, agenda setting and grooming with the patients. There was no real flow and no analysis of it. So we contracted with Moss Adams and are still in contract with Moss Adams, and we have taken time to develop over 300 of our employees with, and we'll talk a little bit about that, but with lean skills of learning and curiosity and projects kind of setting it up for, things to stick and working it through. This is probably the biggest thing. So we have 30 plus primary care and nursing value streams that are going forward right now. We have 14 mental health initiatives going forward and 5 dental improvements that are actively going forward. We're doing what's called operator standard work, where you map out the process and you make sure kind of what the things that everybody should make sure that they do, and then where the discretionary kind of things are for the procedures that we do. So we're extending to psychiatry, clinical pharmacy, and then our social work teams and addiction care teams this year. So a lot of activity happening. 5S is where you go through and you clean up the environment, you clean up the supplies, you clean up the logistics chain, you clean up how you document and the process for that. Everything to be where it should be, everything have a place and everything in its place is the idea. And we, correct me if I get my math wrong, Dave, the first workshop that we worked on pharmacy waste, like overstocking in wrong places and putting stuff, like kind of all over the place, and then reordering. I think it was $78,000 that we found of waste that we could redeploy into the system and not have to purchase again. And we kept doing that, and we'll continue to be doing that to be value added for Washington State.
Based out of the work that we've done with the patient-centered medical home, Dr. Curl and I identified that we needed to maintain a lean transformation office to ensure that the investment that we're making in staff, that we continue to train people in all of the lean principles, that we do reduce waste in every way that we can, and we continuously look for and we establish continuous improvement everything that we do. We're committed to it. We have funded it ourselves out of positions. We look for ways to at least get the office started. It's not as large as we need it to be, but we do have the foundational piece in place.
We started the patient experience committee. We have not ever had an organized patient survey to ask them, how are we doing? How can we improve? It was very haphazard, and now we have, this has been about a year ago that we actually launched our first electronic kiosk-based survey for our patients. We're working to make that more robust. I have just put in a request through the IRB to do research on the language that we use in prisons and what the population wants to see in terms of how do we reference, I think people, will say prisoner and people cringe with that, or inmate and cringe with that, or incarcerated individual, or it calls them adults in custody. And I call them patients. Mark Stern, who you may know, and I had a little laugh because I said, well, when people maybe want to be called residents, and he said, well, in the jails, they sure don't want to be called residents. And I said, well, gosh, what are we going to do? So now we're working with a group in Europe, Australia. We're working on an Asian counterpart, and where else? America, Canada. To do a research study that is getting the feedback from people who are currently or have experienced incarceration. What language would they prefer us to use? We have a full infection prevention program. Work with the Department of Health and the state epidemiologist as well as the CDC. As you would expect, just like a military college and carceral setting, outbreaks are a different thing than what you deal with in the community where people are living in a congregate setting. So hepatitis C, TB, COVID, other kind of concerns like scabies, stuff like that comes up and it comes up. I think, am I still doing that? Am I doing this? So, this one is just to say, we are not at all where we need to be on medication for opioid use disorder. Society is not where we need to be. And we are continuing to work to tell our story and to, you can see by the graph that we have a population of over 3,000 that's identified by basic identification. I wouldn't say necessarily, they're asked several times, but it's all kind of them talking about it. The thing that I find oftentimes is if we can connect with that person's life before they came to prison and we could get some data flowing a little bit, we might be able to say, you were in this emergency. When we do reviews on when people pass away, we have a little bit more a look back into history than we do on a regular basis with men. And I've found that emergency department visits for, particular things kind of can help me piece together some of the story for them. So we're working at pulling that information into our system so that we can say, hey, it looks like in the last year, you've been in the emergency department with this intoxication like 3 times. Is this a part of your story? Is this a part of what we need to talk about? How to do that?
Standard that every day.
100%, every single one. And those that are unexpected deaths go through a secondary review where we review that with the Department of Health, the Healthcare Authority, and the ombuds. And I'm in every single one of those. So again,
What's your autopsy rate?
less than 10%. And we ask for it 100% of the time, but it is not us paying for it. It is the coroners paying for it. And when we get a no, I call the coroner, either our civil event coordinator or I call the coroner and have a conversation around it. As you can imagine, like a week ago, I had a 93-year-old man pass, and the coroner was not planning to do an autopsy. I get it. I really do get it. And we have families who have disconnect and need to know in a different way than families who are not involved in the justice system. And so advocating for that is a part of our advocating for them. And we ended up not doing the autopsy, and we did the right thing, I think, but having the conversation is 100%. We do have CBT or addiction care, and we have a combination of DOC employees and contracted people who give that care, and we're continually working for that to be stronger and to cover what people need. We also have, did you want to talk about this one? So we have sex offender treatment. And I will share with you that before I started working for the Department of Corrections, I really kind of thought it wasn't effective. And actually what we have found and then what we've proven is that it is effective actually for reducing the recidivism rate, which means another charge, another crime. Treatment actually does work. And I was not a true believer on that before I worked in this area. And I think that's something that the average Washingtonian needs to know, that investing in that treatment actually does reduce sexual violence and the sexual crimes that happen. really big deal. So how can you help us? This is my plea. I'm working, we did credentialing, Dave and I had training, and I'm working really hard on professional standard boards, peer review, and privileging. And if anyone has any help or artifacts or ideas or resources or anything around setting up, I was in the VA before I was with Washington State. And so I know what a good peer review program looks like. The VA peer review program is very robust. So I know what that looks like, but if anyone has an idea of, setting things up or if the commission has resources, we are saying yes. And we're planning on starting with kind of concentric circles, physicians, PAs, and nurse practitioners as a first priority, and then actually all the affiliated groups. So it would be super helpful.
As we've already shared, we do not have an electronic medical record. We're 100% paper-based. We are part of the agencies in the enterprise solution. There's also a proposal for a DOC electronic medical record solution outside of the enterprise solution. We are looking for allies for any opportunity you get. Please speak to the fact that the Department of Corrections absolutely needs to have an electronic medical record to be able to provide quality of patient care that we seek to offer our patients.
We want to partner and we want to be held accountable for that partnership. When we have people transition to their post-prison lives, I expect that the information that is needed by the community provider is proactively provided. I expect that our patients are involved in that they're informed of what their appointments are, why they have appointments to make. And if anyone's, working in the community to hold us to it, that's what we want to be doing is coordinating care where there's a warm handoff. We're working with the hospitals in the state to reduce the barriers to excellent communication between Department of Corrections clinicians and hospital-based clinicians. It's surprising how much incarceration brings the myth of you can't talk about this. Our patients are the same as other patients. There are particular things around communications with victims and some of those other pieces that we can help to inform. But more often than not, what we get is this cone of silence around our patients that can be really an impediment to delivering excellent care. So we're constantly trying to reach out to reduce that factor.
So do you have any research you've done to look at healthcare discharged experts or better community participated and able to work and therefore is less likely to offend, as you said? I mean, you go to somebody and say, well, we should invest more money in trying to keep people well or get prisoners well, because in the end, you'll pay less, they'll cost you less, and less the community will be better off.
We do.
Have that data.
We do. Yeah, we have a number of places where we have that data. I can the CAREI, CAREI is one of our psychologists at the women's prison, and she's published a number of papers on treating trauma and the recidivist rates among women, and what happens there in terms of whether this person becomes a productive member of society. So that's a recent, right? CAREI is her name. And I'm glad that you'll give me your contact. I'll throw you some papers because we do want some data, and we do seek we have research ongoing, and we seek to validate whether or not, we want to know if what we're doing is working. And if it's not working, we want to change it, Yeah, absolutely. So that,
Washington State was the second state in the country to be approved under the 1115 waiver. We are participating in the Medicaid transformation project. Under the 1115 waiver, there's 3 mandatory requirements. Patients having MOUD on release, case management on release, and access to medication, leading with medication for all of their conditions at release, so 30-day prescription for each medication and 2 prescriptions. I'm sorry, I said on release. Under the waiver, patients are eligible for case management the last 90 days of incarceration. So we're working with our staff to ensure that there's a strong continuity care plan for patients with release. Our first cohort under the waiver is going into effect in July. We have 3 prisons, Washington Correctional Center for Women, Palm Bay Correction Center, and Abbey Ridge Correction Center, which will be our first cohort. Also, as part of capacity build under the waiver, we were allotted funds to be able to expand Wi-Fi in our prisons, and we have also working to put telehealth booths and living units, so patients will have expanded access to care through telemedicine.
yeah, the current standard is that we have one office that is used for all things tele, which might be hearings, virtual hearings. So compete someone's community telehealth appointment with someone getting their hearing. And tell me how many times you win that argument. So we're looking at actually purchasing privacy booths that are in the living centers, in the day rooms, so that people can have their private telehealth appointment and expand. Also hiring more medical assistants to facilitate the visits. And that, we'll take any questions, but also I'm just telling you, I'm the conduit. I'm here today. If it'll take you into a while, well, any of us will. If you want to see a prison, we are delighted to show you. And you know, we can have several of you or one at a time, and we're glad to help to arrange a visit. It's a different experience, and that's for sure. So, make any questions. And we're probably way past our time.
You're fine.
Actually, you're doing it. I will open it to folks in the room. It doesn't look like we have anybody online who has their hand raised. But before we do that, I wanted to say thank you. As you promised, this was sort of a revelation. And again, as I was mentioning to David, you know, the commission gets parachuted into random cases periodically, and we struggle sometimes with understanding just some of the parameters of what you outlined. So thank you for coming and educating us.
We've gotten funding for this year. And we're in the kind of the pre-work phase of getting things ready, looking at hiring, looking at work charts and that kind of thing. Dave, when will we know for future?
We will know this next session. We will know what comes out of the state budget.
And you've chosen Epic, which communicates to all, you know, all the big hospitals in the state of Washington.
Yes, I think the very first specialists that we work with operate under that. The second solution that we have proposed where shows the employee care about it. And so we know there's still a lot of discussion that taking place, and we want to have best electronic medical record for patients that have best outcomes for our providers and the information they think is going to do. We think one solution is better than the other. I think I'll only speak for myself. I think one solution is better.
what it is.
Yeah, 90% of Washingtonians have that record, so.
If you need a letter from the commissioner that supports you in getting out there, just let us know.
But we'll take it. Yeah, absolutely. That's, I mean, that's absolutely, that's part of the, please help.
All in
us.
favor?
Awesome, thank you. 50% of Washingtonians have an epic record. Why would we not be, a platform for public health? I don't see how anyone can sell a different model than and be connected to the jails and get it all to where Washington is transparent about the quality of care. And, all we have to be afraid of is if people are hiding out and not being seen, delivering substandard care. We find it, root it out and change it. And if people need to move along in their career to, gardening a patch somewhere and we're okay with that. That's, unapologetically, we demand it.
My second question was an observation of inmates getting transferred and losing their pending appointments and it not being communicated to the new facility. And then they get transferred again and again and again, and it results in severe delay in care.
Yeah, so we have a facility medical director transfer call that has over 90 people on it every single Monday. And what we do is we coordinate exactly that. We're trying to have that not ever happen, and it's still happening a little bit. So because for custody reasons, people will move and our custody partners won't realize that they need to coordinate because they don't have access to our health services, for privacy reasons. They don't have access to all of our pending appointments and things like that. I have a dream, and actually Dave and I just put it onto a wish list for the agency to create of having a transfer dashboard that is transparent across different functions, like if students in school, or if they have a job, or they have, some extenuating circumstance with their family where they really need to stay in that community, make it easier for us to do the right thing. Because what happens is you move that person, their appointments get canceled, or their loved one is going through cancer care, and they really needed to be in that community for a visitation or whatnot. And then it has to go through the, we call it the resolutions route, because we like to put a positive, kind of mentality in everything. The complaint route, whatever grievance. And we still need to deal with it. Why not prevent it from happening? I completely agree with you. That continuity of care is an enormous thing for us. We also have gender affirming care transfer conference. We have mental health transfer conference, and then the dental jumps in on the medical one. So we have several that every single week we coordinate that transfer of people.
We do have one question from our internet friends. It says the PCMH includes shared decision making. Did you include this?
Yes, and more of that. Absolutely. And shared in the families, shared in the chosen families, shared in peer-to-peer discussions, shared from the patient to every team members being respectful and responsible with each other, open to good ideas, and there's no wrong door to coming to the right solution. Absolutely, 100%.
Two questions. The first one, very easy, is would a pre-guided tour include a tour of the healthcare facilities?
Sure, absolutely. Absolutely.
That's why we're gonna take you to.
I want to show you.
The second question is more like a question or request. First of all, please try to spread this to the local jails. They need it. But my question is, have the prisons looked at sleep and quality of sleep? This is not only a determinant of health, but I know in the jails, you mentioned you're sleeping on a mat, concrete floor. Well, in the jails, they sleep on a gym mat, twin-size gym mat on a stainless steel shelf.
Yeah.
And they don't get a pillow, and they have one twin-size burlap blanket. And every time I go in to visit, everybody is sleep deprived. And the interesting, you mentioned medical approval for a mattress. I have a guy now who's waiting for a multi-level cervical disc, um, a multi-level cervical disc fusion. And I got him to send an RFI, and I talked to his neurologist, what's the post-surgical plan? So I'm just gonna release it back to the gentleman. And you know that they have a thin mat and no pillow, or well, that won't work. And so now we're trying to find an inpatient rehab facility that can take, but anyway, it's a safety issue too. My clients have inhibition problems already, sleep deprivation, and makes it a thing.
It's your best foot forward to be sleep deprived for sure. We do treat sleep disorders and we hunt them down. So they do have, our patients have CPAPs. They have the devices that they need. One specialty I forgot to mention is Dr. Ball, who is the facility medical director out in Walla Walla. He started the Walla Walla Clinic's sleep clinic. And so he was a great, I wooed him for about 18 months, Dave, like chasing him around and every, like, please. And he's helping us really work on the statewide standards for sleep. And we do believe in the foundational kind of elements of lifestyle, meaning you've got to eat half decently. We've worked really hard to improve the quality of the food that people get, the proteins that they get, the freshness of their food, the commissary food that they're able to purchase, all of those things. I won't really personally rest until we have farm to table to doing hospitality training so that people, when they get out, can get a job in the hospitality industry. So I'm a little bit nuts on that, but that's me, right? Sleep and restorative sleep is absolutely one of the 6 foundations and pillars of healthy life. Managing chronic illness and reducing toxins. These are the things we talk a lot about, obesity, diabetes care, hypertension care, cardiovascular risk reduction, cancer risk reduction. All those things go together, and sleep will knock them all out of the park. If you are not restoring your body, exercising, drinking water, and sleeping, you can't be healthy. So you're spot on.
We've also established peer groups for people that have like diagnosis. They can come together, educate one another, talk about what their condition does to them, and really just broaden people's knowledge around their health.
I'm good. I would take my stepson.
You're very consistently. Why should we pay for it?
I see Roblox around here.
They didn't have healthcare before they went. On a moral level, you should do something, on an ethical level, we know that may not be in people's minds right now, and a significant portion of our citizenry. And so, unless you talk to some people here and see it maybe transactionally that you're paying less in the long run for society, or you have what foundations for the rationale for treatment, do you approach this citizens, or do you reach out to the community?
Well, first, I think the question is, why do things people not have access to care and prior information? And the response to that, we have a legal responsibility to provide community standards of care to patients. Our patients have a constitutional guarantee for care. We could say more, but I don't think we need to. We have a legal requirement.
And if you consider the jails, the majority of those people are in pretrial custody, meaning they've not been found guilty. And the first line we all learn in high school civics class is, you are innocent, what? And there you go, until, even the proposition, until bakes in our biases, supposed to be innocent unless proven. But even in jail, they're in these really punitive environments and they're innocent, and yet we're depriving them of this liberty. They are absolutely entitled.
Yeah, I think it's a false economy because pay now or pay later. That's the thing. Would you rather do preventive care or catastrophic care? And there is a great book on the philosophy that I'm espousing. It's called Compassionomics. It is a meta-analysis, a gathering of all meta-analyses on does empathy and compassion actually matter? Is there a scientific basis for this actually being economically appropriate, and heck yeah. There are 3,000 studies in that book. It is absolutely enormous. And it is scientifically proven that this is the cheaper way to go.
And it doesn't take additional time, and it doesn't cost any money.
No, it saves money. It saves money. That's compassionomics. It is the tone that will help, you to articulate the why behind this. I mean, if you're just going economics, that's easy. I mean, take one catastrophic case and ka-ching it out. It's $10 million at least for like this the last part of the last catastrophic case I remember. And I mean, that's just the payout on the, like, we think of the human suffering and all the things around, that's easy economics. I love that question. Thank you.
Dr. Curl, I think we're going to put a pin in it for the time being. I want to say thank you again for coming, and hope that you'll consider coming back, maybe next year or the year after. Thank you again to you both. She had a great one. She's gone to the commission. She was